So my name's Luke. I'm a UK qualified doctor, also who worked for Save the Children for 9 months this year in Sierra Leone. And today I'm going to present data from a research project that we conducted while we were out there, looking at some of the haematological and biochemical parameters associated with Ebola and their associations with outcome. It was a multi-organisation collaboration. We had help and kind of technical advice and support from the Sierra Leone Ministry of Health and Sanitation, the Liverpool and London Schools of Tropical Medicine, Public Health England, the UK Armed Forces, and Save the Children, who I worked for out there. And this paper has just come out in the Lancet today, so if you are interested, have a look. So just a very brief background about Kerry Town. It was a large Ebola treatment centre, very well organised, which opened in response to the current outbreak. Unlike previous outbreaks, because of the nature and the scale, they were very well resourced and well funded. We were fortunate enough to have an on-site lab that would process biochemistry, haematology and virology for us with a quick turnaround time. And we looked at previous literature surrounding this, and there wasn't really any data out there assessing the prevalence of kind of lab abnormalities, and certainly none that had linked it into key clinical parameters. So our goal really was to study this in more detail, with the hope that we would be able to perhaps provide some insight into the pathophysiology of Ebola, inform clinical management algorithms for future outbreaks, and understand key variables associated with outcome. One of the most difficult tasks in an Ebola treatment centre is actually recognising who is dying and who isn't, and often when you have a resource-limited situation, that would be a really useful idea. So to understand the results, it's important to understand how we treated people at Kerry Town. And we developed a staging system in conjunction with the UK Armed Forces and in reference to the World Health Organization guidelines. And when a patient came into the centre, they'd be assessed by a physician within about an hour of arrival. And they'd be triaged into one of three categories, so either early, mild disease, gastrointestinal disease, or severe complicated disease. What we found is that all patients, when they present with Ebola, present with very non-specific features similar to malaria. They have a fever, weakness, lethargy, sometimes a headache, often profound muscle aches. Typically these patients are ambulatory and able to self-care and compensate for fluid losses through oral rehydration alone. So we tended to offer these patients ORS in the first instance. It's a salty drink, basically. Symptomatic treatment, and if the RDT was positive, we'd give them an artesunate derivative. We also tested all patients on admission for their serum biochemistry, haematology, and viral load. And based on that, we offered them targeted electrolyte replacement and IV fluid support if required. So about 2/3 of patients then went on to develop gastrointestinal stage, which was typically kind of diarrhea, vomiting, and abdominal pain. And the diarrhea you get is very severe. It's often up to about 5 litres per day. It's very green, watery diarrhea. And these patients are often quite profoundly dehydrated on arrival, very much unable to compensate for these large losses through oral intake alone. And as standard, we resuscitated these patients and we gave them maintenance fluids of between 3 and 6 litres a day. We also gave them ceftriaxone. There was a paper that came out earlier last year, a case study of a Westerner who came back to Europe and developed a gram-negative septicemia. So based on that, we gave all patients ceftriaxone from stage 2 of disease. And then a minority of patients, about 1/3, would then go on to develop complications of Ebola, Typically, this might be clinical hemorrhage, could be shock, hypotension, neurological involvement. Often we saw hypoactive delirium amongst these patients, and or signs of severe organ dysfunction, clinical severe organ dysfunction. These patients were critically unwell, often profoundly hypovolemic, confused. They could have seizures, they could be bleeding. So we treated them as per stage 2 patients, plus as indicated we could sedate them, give them antiepileptics, vitamin K, and fresh frozen plasma where available. We shared our site with the UK Armed Forces, who had a blood bank, and sometimes they let us have some. So essentially a patient would come into the centre by ambulance. They'd be met by a group of people who would decontaminate the area, bring the patient in, and then they'd be triaged straight away into either stage 1, 2 or 3. And this was really useful because it meant that that colleagues who perhaps weren't particularly experienced in dealing with Ebola, either on short deployments or perhaps not necessarily trained, would be able to initiate treatment, and it would be a standardised therapy. So our study design, we performed an observational cohort study of all patients admitted over a 1-month period during the peak of the outbreak. We recorded their demographics, their disease stage at admission, and we recorded their reverse transcriptase PCR cycle threshold, which is a proxy for viral load, their serum biochemistry, haematology results. And we studied the association between these and outcome, and I'll present some of the analyses. And our primary outcome measure was discharge from the ETC. So over the study period, over the month, we had 150 patients admitted with PCR confirmed Ebola virus. Of these patients, 118 had blood tests within 24 hours of admission and were eligible for inclusion into our study. Reasons for not having a blood test, our analyzer went down for 3 days over one of our peak periods, introducing probably a random bias. In 8 patients, a sample wasn't taken. Looking at the comparison between the 150 and the 118 patients, there was a similar case fatality rate, and in terms of male to female ratios and ages, they were comparable as well. So our case fatality rate was 36% overall. We found that the disease stage in admission, unsurprisingly, was associated with mortality, with about 2/3 of patients with severe disease dying, and only about 25% of patients with early mild clinical disease. I won't bore you with this table. So just going through some of the parameters that we measured, we looked at viral loads. We measured viral loads using the Altona RealStar filovirus kit following virus inactivation and manual RNA extraction. And what the kit gave us was a cycle threshold, which is a semi-quantitative measure of viral load. You can see in this column, in this row, in this table, you can see patients who survived, patients who died, the total number there as well. So you can see, based on this results, that a high viral load or a low cycle threshold was significantly associated with mortality. In those that died, the mean cycle threshold was 18.3, and it was 23.4 in those who survived. That's, I guess, unsurprising, really, that patients with a high viral load are more likely to succumb to the illness. We also measured creatinine kinase, and you can see quite significantly that creatinine kinase was elevated on all patients. So the median CK was 1,500, and again it was associated with mortality. Now, creatinine kinase hadn't been really measured before. What we suspect is that this potentially indicates that Ebola affects many cells within the body, particularly the muscles, causing a myalgia. We looked at the liver dysfunction as well. It's unsurprising and not new that Ebola causes liver dysfunction. What we saw was transaminitis, markedly elevated AST and ALT ratios. Transaminitis was common, with over 70% of patients having AST, ALT more than 5 times the upper limit of normal. We measured the upper limit of normal as per normal values for the UK-based population. Unfortunately, there's not much data for that in Sierra Leone. We also found that a severe hepatitis, AST more than 15 times the upper limit of normal, was more common in fatal than non-fatal cases. Interestingly, bilirubin was normal in the vast majority of our patients, probably indicating that fulminant liver failure isn't particularly associated with the clinical syndrome of Ebola, and it's more of an inflammatory picture. We also looked at AST-ALT ratio. Again, this isn't a new finding, but it certainly corroborates our results, and probably an indication, again, of diffuse cellular damage as a result of Ebola, as opposed to just a pure liver inflammation. We measured the prevalence of acute kidney injury, and we found that in all patients with Ebola, acute kidney injury was common, occurring in about half of cases. And you can see the median creatinine in patients who survived was 90, and 467 in patients that died, and that was on admission. Acute kidney injury was associated with mortality, occurring more commonly in fatal than non-fatal cases. And interestingly, when acute kidney injury did occur, it tended to be very severe. So we used the rifle scoring system to look at acute kidney injury, and we defined severe acute kidney injury as a creatinine change of more than 3 times from baseline. And we found that, as I say, severe acute kidney injury is associated with fatal outcome. Interestingly, 29% of patients with stage 1 disease, so this is the patients who just have a viral type picture, they're usually relatively well hydrated. These patients, 28% of these patients had a severe acute kidney injury. The traditional hypothesis for the development of acute kidney injury in Ebola is of a prerenal syndrome, where patients become very dehydrated as a result of gastrointestinal losses and fevers. But we demonstrate here that the etiology for acute kidney injury is potentially multifactorial, with a number of potential hypotheses. We didn't investigate this further, but obviously with significantly elevated creatinine kinase, you have to worry about rhabdomyolysis. DIC is another potential. I know that there was a study in 2007 where they measured D-dimer in patients with Ebola, and they were elevated in most patients. But certainly, given the fact that there's a significant proportion of patients with early disease with severe kidney injury, this is worthy of further study. We also looked at serum potassium and sodium, and what we found was that an abnormal potassium result occurred in a third of patients on admission, with similar proportions having a low or a high potassium level. This really highlights how complex Ebola virus disease can be. Often the patients who are hypokalemic would be the ones who had a normal kidney function and had severe diarrheal illness, whereas the ones with the hyperkalemia often had a severe acute kidney injury and were therefore unable to dispose of potassium. But it highlights the importance of targeted electrolyte replacement in these patients. There isn't a one rule fits all strategy for managing electrolyte imbalance in patients with Ebola. We also measured serum sodium, and we found that hyponatremia, low sodium, was a common finding, but it wasn't associated with outcome in analyses. And we also looked at haematology. We had some quite surprising results here, in that a higher mean hemoglobin, a high hematocrit fraction, and a higher median platelet count were all associated with adverse outcome. Now, we expect that this is probably a surrogate marker for intravascular depletion, i.e. patients that were very dehydrated or ones who had lots of third space losses through severe inflammation were likely to have a poor outcome. We looked at platelets, and thrombocytopenia was common, occurring in about 30% of patients overall. Thrombocytopenia occurred more commonly in non-fatal cases. Interestingly, severe thrombocytopenia, platelets less than 50, was very uncommon. It occurred in 3 of 118 patients in our study. And we believe that given the nature and the high prevalence of bleeding in patients with Ebola, certainly coagulation, although it wasn't something we were able to measure, is very much worthy of further study. But it's likely that this isn't a consumptive coagulopathy causing hemorrhage. So we plugged all of our data into a multivariate model. Any measures that were associated significantly with mortality in univariate analysis we put into a linear logistic regression model. And we were essentially looking for independent risk factors for mortality, with the aim of being able to predict who would do very badly and who would do well. So the results of this are that a low cycle threshold, i.e. high viral load, and severe acute kidney injury are both independently associated with mortality in patients with Ebola. So you can see our confidence intervals are quite wide. So we didn't really find that magic bullet answer. So we had some limitations to our study. We had some ceilings of measurement for our assay. We also probably had some limitations in the fact that in Sierra Leone, patients who developed a fever and met the case definition for a suspect case of Ebola would go to a holding centre for confirmation of Ebola before being transferred onto a treatment centre. This, combined with the lack of treatment centre beds in late 2014, meant that there were some delays in admission. So the mean time from symptom onset to admission in our patient group was 5 days, and it might well be that some patients died before arriving. Conversely, often the more unwell patients would be prioritised or transferred to a treatment centre bed, so we're unable to really pick that apart. But certainly caution should be used when comparing the case fatality rates between centres. So the conclusions really are that the clinical syndrome associated with Ebola is complex. It involves inflammation and cellular death throughout the body. It involves multi-organ dysfunction. There's intra-individual variability in susceptibility to severe disease. This is relevant because obviously some people who don't display severe symptoms might be potential, participants for further study into this. Now, crucially, we demonstrate that aggressive supportive care, tailored electrolyte therapy, are achievable in the context of an Ebola treatment centre, and because of the high prevalence of organ dysfunction and electrolyte imbalance, this is really important. And I would suggest that this would be really good information for future planning of Ebola treatment centres, and really we should be, doing our very best to provide decent supportive care, including blood testing and aggressive intravenous fluid therapy, rather than just traditionally the rehydration that perhaps was administered in the past. Okay, thank you.
Thank you, Dr. Hunt, for sharing us these unique laboratory data of the Ebola patients you have helped. Are there any questions?
Yep. Thank you for a very impressive talk. It was really interesting and very well worked out, I think. I have a question on the last analysis you have here, because you said at some point, that one, you said at some point that when you entered into your system, you had a phase 1, phase 2, and phase 3 thing that you assigned people to,
Yes.
and your treatment was dependent on the categorization there. But you also said that, I think what was it, 28% of the people in the light category did have an acute kidney injury.
Yes.
And that seems here to be a significant part or a significant factor for the outcome here. But it also meant that these 28% would be given another treatment. So did you consider involving the treatment in the analysis here?
Unfortunately, we didn't collect data on the specific treatment received by patients, so we weren't able to do that. But certainly, I think that would be a very interesting and promising thing to do. I think overall, despite not really being able to conclusively prove that intravenous fluid therapy and electrolyte replacement were associated with a decrease in mortality, I think given the weight of data in this and other studies coming out at this time, it's quite conclusively reveals that it is a good idea in these patients.
Further questions? Yeah.
For the RT-PCR viral load, did you do that only once on admission?
So we did it on admission for everybody, and then as they got better, we would then do another viral load. We didn't track it over time.
So would that be a useful thing to be able to continuously monitor it and use it as a potential marker of how, if the disease is going to get worse or better?
Potentially. It's not something we looked into. I'm not sure what the evidence is around that area. But certainly we did find that patients with a very low viral load on admission were more likely to have an adverse outcome. Very high viral load on admission, low cycle time.
And you've got a CFR of 36%, and I think in the media it was reported about 50% or so. Is that the disparity between people not getting to your place, dying very quickly?
Yeah, so I think that's quite a complex question, and potentially that could well be the case. We're unable really to draw many conclusions from our potentially lower case fatality rates because of the model of patients not arriving quickly. We don't know how many died beforehand.
But you can presumably draw from the fact that when people arrive at stage 1 in your place, that their likelihood of mortality is a lot lower, so your care seems to improve mortality rates.
Potentially. Yeah, not sure. Yeah. Okay.
Further question? No? Thank you for your contribution and sharing these data with us.
Thank you.
And for you also